Thank you, Sandhya and Drishti2024 for giving me this opportunity. So, today, with the modern technology, cataract surgery is one of the most routinely performed and, refractive surgeries with excellent results, and high expectations are there from both patient and the surgeon. So if you get a double vision after cataract surgery, it's a major distress not only to the patient, but a big surprise and disappointment to the operating surgeon. So let's look at some case scenarios. So this was a 40-year-old IT professional. He was myopic and he underwent femto-assisted laser cataract surgery in the left eye. Post-cataract surgery, he got very good vision, plano 66N6. But this is his response on the glass appointment day. Doctor, everything is so clear, but double. And patient is clearly unhappy. So what went wrong? So he was myopic earlier. With the right eye, he's still using his myopic correction. He has 6/6 vision, both eyes. What did we miss or what did we overlook? So this is what we overlooked. He had an intermittent exotropia, which was missed, and it was more, decompensated in the left eye. What went wrong? So when a throwback into the past, he was anisomyopic, means he had more myopia in the left eye. He already had an intermittent divergent squint, but he was able to control it with his fusional convergence. But with the onset of cataract, it broke. The fusion was disrupted and it manifested into an exotropia of the left eye. And post-surgery, he regained his vision. Alas, the vision is so clear, but everything is clearly double. And that's the problem here. So what did we do for this patient? So he was extremely unhappy. He spent almost $1 lakh for the femto laser, and now he has double vision. So we tried everything, orthoptic exercises, prism glasses. He wasn't happy. Finally, we underwent and took up squint surgery for him, and he's now happy because he's able to see single. So you have to be careful in such patients, especially anisometropes with unilateral cataracts. When you're operating, please look for preoperative deviations. Counsel them for the postoperative diplopia possibility and the possibility of a squint surgery. Let's look at another case scenario. A 32-year-old gentleman, he had trauma in childhood. He had undergone corneal tear surgery, cataract surgery in childhood. He wasn't rehabilitated with glasses, so he had poor vision. He came to us for a checkup. In our enthusiasm, we checked him, and with a phakic correction, he was improving to 612N8. So why not do a secondary IOL? He'll get good vision back, right? Yes. So we did a scleral fixated IOL for him. Post-surgery, his vision improved to 6/9N6 in the right eye. So this is his preoperative picture, and now you can see he's clearly unhappy. Everything is jumbled up and double. Very clear, but double. So what happened here? Now remember, this was a patient who had trauma in childhood, had lost vision, had long-standing poor vision from childhood. And his fusion was disrupted in childhood at an age when he could neither suppress nor fuse. So he developed an exotropia, but since vision was not corrected, he didn't have any problem. Later on, we deliberately corrected his vision with a secondary IOL, gave him good vision, but clear double. So he landed up in a proposition of horror fusionist. He can neither suppress nor fuse. So even with prism glasses, he was unable to fuse. So this is something that you should keep in mind, especially in long-standing loss of vision, younger patients, traumatic cataracts. Counsel them for post-op diplopia. So this patient is currently on Fresnel prism glasses in the right eye, you can see here, and he's undergoing orthoptic exercises. If he's able to fuse, we will take him up for surgery. Otherwise, we cannot. Let's look at the next case scenario. This was a patient of myasthenia gravis, well controlled on oral pyridostigmine and Vicelone. Ocular movements were full, no double vision preoperatively, had posterior subcapsular cataracts, and underwent surgery in the right eye. Surgery was uneventful, but patient was unhappy. This is what happened. She developed a hypertrophy of the right eye. And this is her diplopia charting, which shows the double vision is more in the right down gaze. So what happened? So this patient had undergone cataract surgery under local anesthesia. And possibility is that probably it induced a myotoxicity to the inferior rectus muscle, and patient developed an inferior rectus paralysis and hypertropia. So in patients with myasthenia gravis, avoid injection anesthesias. No local anesthesia for myasthenia gravis patients. Please do them under topical, because even though they are well controlled, you may produce a new squint and patient will really get angry with you. So this patient was chewing her brains till her double vision resolved over 8 weeks with slow tapering dose of oral steroids. So next case is that of a 65-year-old lady with blurry vision. She had already undergone cataract surgery in the right eye. She had good vision, so she didn't really bother about the left eye. When she had a near total cataract in the left eye, she came to us. Visual acuity was 660 N24 in the left eye. Post-cataract surgery, she had good vision, but on glass appointment, she wasn't happy. She was not able to keep her eyes open. She was preferring to close the left eye. What was the problem? This is the diplopia charting. You can see there is a vertical diplopia, which is maximum in dextrodepression, very typical of left superior oblique palsy. So this was a disappointed patient. What did we miss preoperatively? This was a patient with a chronic right head tilt. We totally missed it. And this is a patient after prism glasses happy, because surprisingly and happily for us, the double vision and the diplopia and the squint was better with prism glasses. It was a small vertical squint we could manage with prism glasses. So if you look at the etiology of post-cataract surgery diplopia, it could be surgery-related, anesthesia-related, optical or refractive, but most of them are due to pre-existing strabismus which is missed or a new onset of strabismus. So already these conditions have been described. Surgical technique can sometimes lead on to double vision, but it's usually the anesthesia, especially retrobulbar anesthesia or peribulbar anesthesia, which can injure the rectus muscles, most commonly the inferior rectus, which can produce a vertical squint. Sometimes it can be ischemic injury or an inflammatory reaction, but surprisingly these are rare in today's scenario because of our shift to topical anesthesia. I'm not talking about this because it's been already described and discussed, but pre-existing missed disorders are the most common, especially a patient with dysthyroid ophthalmopathy with subtle redness coming to you. You may totally miss the injection over the recta and think of it as a conjunctivitis. Oculomotor nerve palsies, which are subtle, you may miss it. Myasthenia gravis, decompensation of a pre-existing heterophoria to tropia, horror fusionus, as I already described, in young patients with post-traumatic cataracts. And rarely, pre-existing macular conditions may be missed, like an epiretinal membrane or a macular pathology, which can produce true uniocular polyopia. So this was a study we had undertaken in our center to evaluate the incidence and causes of binocular diplopia following cataract surgery for a period of 6 years. And what did we find? Out of the 48,500 cataract surgeries which we did at our center, only 38 patients we could get with true binocular diplopia. That is a very small number, 0.078%. So this is an agreement with Costa et al.'s publication in which they found an incidence of 0.09%. But you know what? Surprisingly, 74% of all these patients who had binocular diplopia had double vision looking towards the operated eye, and they attributed everything to the surgery. So that is the big catch here. So what we found was that the majority of post-cataract surgery diplopia is due to a pre-existing cause, most commonly being a decompensated foveatotropia, mainly exotropia. New onset double vision is usually due to cranial nerve palsy, most commonly a superior oblique palsy, which is very subtle and may be difficult to pick up unless you really look for it. So preoperative missed diplopias again were due to pre-existing superior oblique palsies. Local anesthesia-induced diplopia is rare. With topical anesthesia, the risk is hardly there. And what we found that a simple binocular vision assessment, including Wurtz-Fodor test, stereopsis, Hirschberg tests, in most of the cases picked up the pre-existing double vision. And if you are suspicious, do a diplopia charting, and that would pick up the majority of the preoperative diplopia of about 95.2%. And also, what do we do for these patients? If at all you have a post-op diplopia, you could manage them with prisms or orthoptic exercises depending on the condition, and some of them will have to be taken up for squint surgery also. So the learning points would be that diplopia after cataract surgery is surprisingly rare and infrequent, but if it happens, it's going to cause you a lot of trouble. So be prepared to handle it. So basic binocular vision assessment, including a Wurtz-Fodor test, stereopsis, ocular movement analysis with or without a diplopia charting should be an integral part of your pre and post-op assessment. And I would recommend that all of you cataract surgeons take 1 minute to examine your patients in undilated state, because that will give you a clue regarding presence of any abnormal head postures, ocular misalignments, pupillary anomalies. And if you detect any problem of preoperative squint or double vision, do inform the patient about the post-op diplopia and the possibility for prism glasses and squint surgery. So the best approach is to anticipate in suspected cases, communicate with the patient, and be prepared to tackle it. Thank you very much.
Thank you, Neena, for that excellent presentation. I've got just one doubt. Some of these patients with mature cataract, they have a divergent squint. Do we have to do a squint evaluation before surgery after listening to a talk?
So yes, I think you please note that they have a divergent squint and inform them that you have a divergent squint pre-existingly, and if you get good vision, there is a possibility that you may not be able to fuse it. So most of them would be ignoring the image, but I have had a lot of adult patients which have done squint surgery after cataract surgery, not able to fuse the second image because of the exotropia. So it is, you should inform, otherwise they'll attribute everything to your surgery. Please take a photograph and document it also.